and whether you will get the disease or not will vary. That is the one quality of mitochondrial diseases compared to the other. Whereas if it is a nuclear gene, if you get it only from one parent, you said that this is heterozygous state. If you get it from both parents, you say it is from the homozygous state. Depending on whether it is an autosomal or a recessive gene, you may get the disease in the heterozygous state or not. You will get the disease in the homozygous state. But in the case of mitochondrial gene, because you have several copies of the same gene, the number of mutant genes per cell is a factor which decides the severity of the disease and whether you will get the disease or not. So that is a property which you refer to as heteroplasmy. If you take the same cell, you will find, say, you have 100 gene copies, 50 may be abnormal, 50 may be normal. At the same time, in a sibling, you may have 75 normal genes and 25 abnormal genes. That means that severity of the disease will be very low. Sometimes another sibling may have only 5 abnormal and 95 normal. Then what will happen? There won't be any disease at all. So that is why the mitochondrial diseases will show what you call as heteroplasmy. Cytoplasmic inheritance is correct. Then codes for mitochondrial proteins. You find that about 30% of the proteins of the mitochondria are coded by mitochondrial genes. The others are coded by nuclear genes. Then, which of the following is a characteristic of diseases resulting from mitochondrial mutations? Anemia, lactic acidosis, mental retardation, thermogenesis. Lactic acidosis, B. You know, most of the diseases which you get as MELAS, they call that LA stands for lactic acidosis. All the following are vectors for chimeric DNA except fat, yeast, retrovirus, cosmate. Retrovirus, see, retrovirus is a vector for gene therapy, not for producing a recombinant DNA molecule. Right? Recombinant DNA, both places you have to have a DNA, isn't it? Retroviruses have got RNA. Recombinant DNA molecules are used for the following except preparation of genomic libraries, preparation of mutant strains, production of vaccines, synthesis of human proteins by bacteria. Answer is B. You don't prepare mutant strains, isn't it? Which of the following is not true regarding viral oncogenesis? Tumor viruses are retroviruses. Viral infection precedes oncogenesis. Mutations in viruses lead to oncogenicity. Viral nucleic acids are detectable in the host cell. C. It is mutations in the oncogenes or oncosuppressor genes which lead to oncogenicity. You know that several viral infections have been associated with the genesis of cancer. For example, HPV virus infection in CA cervix, then herpes simplex infection in oral, then Epstein-Barr adenovirus infections in nasopharyngeal carcinoma. All these are, they are said that this viral infection will insert a promoter and this promoter will facilitate the expression of the oncogenes. That is how it is said. So that is why viral infection precedes oncogenesis. From the pairs of anti-cancer drugs and their method of inhibition, pick out the wrong pair. Methotrexate and dihydrofolate reductase, cytosine arabinoside and time delayed synthase, vinblastine and defective cytoskeleton assembly, adriamycin and topoisomerase 2. Answer is B. Cytosine arabinoside. It is actually acting in the nucleus itself by phosphorylating a nucleoprotein. That is the function of cytosine arabinoside. Even though it is a pyrimidine nucleoside analog, it is not acting as a nucleotide analog, but it is acting as in the cell level itself by phosphorylating a nucleoprotein. And it gets incorporated in the DNA. Then, which of the following anti-cancer drugs is not a nucleotide analog? 5-fluorouracil, 6-mercaptopurine, etoposide, cytosine arabinoside. Answer is C, etoposide. It is again an inhibitor of topoisomerase. Both adriamycin and etoposide are inhibitors of topoisomerase. This topoisomerase is a name given to the DNA gyrase in eukaryotes. 5-fluorouracil is the one which inhibits thymidylate synthase. Which of the following enzymes have no role in genetic engineering? Restriction endonuclease, reverse transcriptase, telomerase, DNA ligase. Telomerase. Which of the following is not a carcinogen? Methylpholandrine, P53, aflatoxin, aniline black. P53. Which of the following tumor markers is most specific? Beta HCG, alpha fetoprotein, LDH, carcinoembryonic antigen. Beta HCG, choriocarcinoma. Actually, it is not only the most specific. The others, you find alpha fetoprotein CEA in the several cancers, not specific. LDH is a general feature of malignancy. In any malignancy, the corresponding fluid will have high LDH activity. Actually, beta HCG is the most specific. Among the tumor markers, it is the only one used for diagnosis. All the others are used for monitoring the patient. But beta HCG is the one which is used for diagnosis. All the following enzymes are essential for replication except DNA ligase, DNA gyrase, DNA helicase. DNA, deoxyribonuclease is DNA. The DNA polymerases has all the following activities except polymerase, 5'-hexonuclease, 5'-endonuclease, 3'-exonuclease. C, 5'-endonuclease. So I showed you all these figures in the beginning, but the idea was you could answer this way. So it's been successful. Which of the following codons serve as punctuator codons? UUU, UGA, UGG, UCU. B, UGA. Which are the terminator codons? UAA, UAG, UGA. See, the difference is that UGA is not a terminator codon in mitochondria. UGA is not a terminator codon in mitochondria. The complex involved in replication is polysome, chromosome, nucleosome, lysosome. Answer is B, chromosome. Actually, the term chromosome refers to a complex of DNA helicase which unwinds the DNA RNA primase which prepares the RNA primer, and DNA polymerase which starts the polymerization. These three proteins are together called the chromosome. What is polysome? See, if you take an mRNA molecule, you will find several ribosomes translating at the same time. We call as a rough endoplasmic reticulum. That is a polysome. Then, what is nucleosome? It is only the DNA molecule winding round the histones or the nucleoprotein. That is nucleosome. And what is lysosome? It is the complex required for splicing of the mRNA. It contains catalytic RNA called riboside, which brings about the splicing. The splicing enzyme is not a protein, it is a catalytic RNA. It is called riboside. The prenatal diagnosis of the inheritance of a defective gene is done by DNA fingerprinting, linkage analysis, DNA footprinting, chromosome mapping. You must have studied in your pediatrics. That is the technique. It is linkage analysis. Linkage analysis. And you know that in chromosome crossing over, you may inherit a gene from your parents or you may not. Then what you do in this linkage analysis is that you don't use the defective gene but you use a marker gene which will be very near to the abnormal gene. Then you look for the marker gene. That is called linkage analysis. You say that the two genes are linked. So if the marker gene has been inherited, that means you will get the abnormal gene also. If it is not there, then you don't get the abnormal gene. That is the. I think I will continue and finish off. Don't worry, the second session will be much more lighter. It is on clinical chemistry. Because I have to finish by 11:30. Of a 9-month-old baby may be any of the following except glucose, fructose, lactose, galactose. The reducing sugar found in the urine of a 9-month-old baby may be any of the following except glucose, fructose, lactose, galactose. Lactose. See, lactose can appear in urine only if it is synthesized in the body, and it is synthesized in the body only by the 3rd trimester of pregnancy or by lactating mothers. A patient with Addison's disease may have all the following laboratory findings except plasma pH of 7.3, plasma sodium of 120 millimoles per liter, plasma potassium of 5.6 millimoles per liter, urine specific gravity of 1.004. What is the basic abnormality in a patient with Addison's disease? Deficiency of aldosterone. That means patient will have hyponatremia and hyperkalemia. So, 2 of your alternatives you have excluded. Now the only thing remaining is plasma pH of 7.3. Plasma pH of 7.3, is it normal or abnormal? Abnormal. Acidosis or alkalosis? Acidosis. Is there any chance that a patient with Addison's disease will have acidosis? Yes. A patient with Addison's disease will have diarrhea. The patient will lose bicarbonate. Patient will get metabolic acidosis. When do you get metabolic acidosis? Metabolic acidosis. You gain acid or you lose base. So here is a condition where you are losing base. In diarrhea, you get metabolic acidosis because you are losing base. Because intestinal secretions are rich in bicarbonate. So you will get metabolic acidosis. Any condition associated with diarrhea. When do you gain acid? When there is production of metabolic acid. Example, lactic acid, keto acid. Or when you are not excreting acid. In acute renal failure, your renal function is abnormal. So acid is not getting excreted, it is accumulating. Then you get gain of acid. Again you get metabolic acidosis. What is the basic difference between the metabolic acidosis due to gain in acid and loss of base? You find that when there is a gain in acid, the anion gap is increased. What is anion gap? It is the difference between the measured cations and the measured anions. Normally it is there, but when you have an accumulation of acid, the anion gap will increase. So, when there is an acidosis due to gain in acid, you get an increase in anion gap. But you may not get an increase in anion gap even if acids are accumulating if there is a corresponding increase in chloride. If there is a hyperchloremic acidosis, the anion gap may remain normal. The anion gap, the chloride will make up for the loss by carbonate. So that is what is happening in renal tubular acidosis. In renal tubular acidosis, there is defective excretion of H-ions, but you find there is hyperchloremia. So what is the condition here? Urine specific gravity of 1.004, is it normal? No, it is low. When do you excrete the dilute urine? When you have to excrete a lot of water. In addition species, you already have diarrhea. That means you have dehydration or contraction of the ECF volume. So naturally the urine will be concentrated. So you cannot have a urine with specific gravity 1.004. And another thing, because of aldosterone deficiency, there is defective retention of sodium. So actually the solute content of the urine will be more. So you find that you cannot have a dilute urine in a patient with Addison species. So answer is D. Then, respiratory acidosis is observed in all patients except bulbar polio, fever, emphysema, obesity. In acid-base balance, it is actually very simple. When do you get respiratory acidosis? What is respiratory acidosis? There is a primary increase in carbonic acid. When do you get increase in carbonic acid? When you are not exhaling carbon dioxide. There is hypercapnia. When do you get retention of carbon dioxide? When there is hypoventilation. So in which all conditions you will get hypoventilation here. Bulbar polio, what will happen? Your respiratory center will be depressed. So there is hypoventilation. Emphysema, the respiratory muscles are not functioning properly. You will have hypoventilation. Obesity, again, the Pituitary syndrome. The obesity will restrict the respiratory movement. Hypercapnia. So you will get respiratory acidosis in all these cases. What happens in fever? Tachypnea and hyperventilation. So you will get respiratory alkalosis. So if you know the basic abnormality in all these four types of abnormalities, you can easily pinpoint the diagnosis. There is no problem at all. In a patient with obstructive jaundice, which of the following will be decreased? Bilirubin, alkaline phosphatase, cholesterol, prothrombin. Answer is D. A diabetic patient's urine may contain the following except albumin, acetoacetate, folic acid, glucose. Folic acid. Which of the following abnormalities is not observed in a patient with COPD on loop diuretics? Respiratory acidosis, metabolic alkalosis, metabolic acidosis, hypokalemia. Metabolic acidosis, see, because patient with COPD will have respiratory acidosis. Patient on loop diuretics will have hypokalemia. Hypokalemia will lead to metabolic alkalosis. All the following conditions will be associated with increased anion gas except diabetic ketoacidosis, lactic acidosis, carbohydrate ketosis, renal tubular acidosis. Renal tubular acidosis. Which of the following laboratory findings is not compatible with the diagnosis of diabetes insipidus? Hypertonic expansion, hypertonic contraction, hypernatremia, high hematocrit value. What happens in diabetes insipidus? What are you losing? There is antidiuretic hormone deficiency. You are losing water. In abnormalities in water and electrolyte balance, whenever you think about an abnormality, first of all you think of whether the unity of volume is decreasing or increasing. When it is decreasing, you call it as a contraction. When it is increasing, you call it as an expansion. So if there is retention, there is expansion. If there is loss, there is contraction. That is the basic thing. Then, depending on the nature of fluid loss, you are losing water and sodium. If you are losing an isotonic fluid, what will happen? You get isotonic contraction. If you are retaining isotonic fluid, you will get isotonic expansion. Now, give me an example of isotonic contraction. You ordinary dehydration. If you are losing isotonic body fluid, then you will get isotonic contraction. If you are accumulating isotonic body fluid, then you will get isotonic expansion. Silent edema and peripheral edema. That is due to isotonic expansion. So, if you look at the type of fluid lost or gained, then you can immediately find out what is the nature of the repair. So, what happens in diabetes insipidus? You are losing more water than sodium. So, what is happening? You get hypertonic contraction because when more water is lost, the remaining fluid becomes hypertonic. Now you look at this. You get hypertonic expansion. You can't because you are losing water. So straight away you can find out the answer. Then you can be sure hypertonic contraction is there. Because of the hypercontraction, even though there is no absolute increase in sodium, the sodium appears elevated, physically relative, and there will be a high hematocrit value. Whenever there is contractibility of volume, the simplest method of finding out is by calculating this or measuring the PCV. If there is a contraction, whatever be the nature, the hematocrit value will be increased. If there is a dilution, the hematocrit value will be decreased. Before the following is the normal serum creatinine level. 0.2 to 0.8, 0.5 to 1, 0.7 to 1.4, 1 to 2. 6. Fecal maturity is assessed by the following except SAM test, bilirubin level in amniotic fluid, alpha-fetoprotein, creatinine level in amniotic fluid. And there is C. What is the basis of SAM test? What maturity are you assessing? Lung maturity. Bilirubin level, you are assessing liver maturity. Creatinine level, you are assessing kidney maturity. Alpha-fetoprotein level has got no influence on assessing the maturity. What is it? Alpha-fetoprotein. So, index of neural tube decay. Which of the following enzymes is elevated in prostatic carcinoma with bone metastasis? Alkaline phosphatase, gamma-GT, acid phosphatase, leucine aminoperoxidase. Acid phosphatase. What about the other three? In this condition, all the three are increased. Polycytic liver disease. All the compounds listed below are normal constituents of urine except indican, urobilinogen, uric acid, urocanic acid. Okay, you are not familiar with urocanic acid, so it cannot be a normal constituent of urine. D. What is urocanic acid? It is an intermediate in the catabolism of histidine. So in such activity, there is something with which you are not familiar, that will be obviously the answer. All the tests listed below affects glycerin status of the body except methionine load test, histidine load test, lymph test, semen test. See, lymph test is a pancreatic function test. Hemoglobin variants can be detected by the following tests except electrophoresis, chromatography, sudden blotting, solubility test. Sudden blotting, correct. Because sudden blotting you are detecting the genetic defect, not the presence of an abnormal hemoglobin. Very good. Which of the following lab data does not confirm a diagnosis of polycythemia? Positive early test with urine, 7 bilirubin level of 15 milligram per deciliter, positive phase test in urine, serum cholesterol level of 20 milligram per deciliter. Answer is A. Positive early test. In polycythemia you may have an absent or low level of neurobilirubin. A patient with respiratory alkalosis may have the following laboratory findings except bicarbonate level of 18 millimole per liter, PCO2 of 20 milliliters of mercury, respiratory rate of 5 per minute, a pH of 7.48. Answer is C. Why the bicarbonate level is decreased? Common case. The compound excreted in urine in deficiency of 21-hydroxylase is homovanillic acid, 5-hydroxyindolacetic acid, vanillyl mandelic acid, 17-ketogenic steroid. And answer is B, 17-ketogenic steroid. Because you find in 21-hydroxylase deficiency, the synthesis of gluco and mineralocorticoids is deficient. That means all the cholesterol which is traveled to the steroid hormone pathway will be converted to the androgenic pathway. Why the pathway is accelerated is because the normal feedback inhibition of synthesis of steroid hormones is by cortisol. If cortisol is not produced, the inhibitor is not there. Which of the following inborn errors is not a transport defect? Immunoglycinuria, cystinuria, Hartmann disease, alkaptonuria. Answer is B, alkaptonuria. It is an overflow type. So you divide the amino aciduria into two types, the overflow type and the renal tubular type. In overflow type, the excretion occurs only if it increases beyond the renal threshold. What is the enzyme deficient in alkaptonuria? Homogenous oxidase, so homogenous acid accumulates. The next question, I think there is a correction this term. The pH is given as 7.48 or 38. 48, it has to be corrected as 48. 7.48. Then PCO2 48 milliliters of mercury, bicarbonate 34 millimole per liter, the most likely causes uncompensated metabolic alkalosis, uncompensated respiratory acidosis, partially compensated respiratory acidosis, partially compensated metabolic alkalosis. Yes, answer is B. Because you can immediately say that it is not respiratory because the pH is elevated. The gallstones may contain the following compounds except cholesterol, bilirubin, uric acid, calcium carbonate. Uric acid. Which of the following test is done in acute intermittent porphyria? Sandy's test, Watson-Crick test, Ehrlich test, Roche test. The answer is B, Watson-Crick test. That is for porphyrobilirubin. In acute intermittent porphyria, there is abnormal increased levels of ALA and TBG in urine. That is detected by Watson-Crick test. What is Sandy's test? It is a simple test with CSF done in suspected case of multiple sclerosis. You know that in multiple sclerosis, the CSF globulin levels are increased. So this is a simple bedside test. You add a drop of saturated phenol to the CSF. If you find an efflorescence, then you assume that the globulin level is increased. It's only a qualitative test. Then, What is Roche test? It is a screening test for heavy metals in urine. A screening test for heavy metals in urine. All the following are features of renal tubular acidosis except plasma pH of 7.25, plasma potassium of 3.5, plasma bicarbonate of 15 millimole per liter, urine pH of 4.5. The abnormality in renal tubular acidosis is either a deficient excretion of hydrogen ions in urine or an inability to reabsorb bicarbonate. In both cases, you will find that there is a paradoxically high urine pH value. Normally, in the case of metabolic acidosis, you excrete more acid, you expect the urine to be highly acidic. But in renal tubular acidosis, the defect is in the acidification process itself. So you find urine with a relatively high pH. It will be acidic, but not as low as you expect in the case where the pH is only 7.25. That is how you should look at it. See, we have heard about the ammonium chloride blood test, where you check whether the urine pH is being lowered below 5.4. If it is not, then we assume that it is a case of renal tubular acidosis. The test for renal tubular acidosis is the ammonium chloride load test. Chronic renal failure is indicated by the following except urine with a specific gravity of 1010, nocturnal polyuria, low creatinine clearance, early morning urine has a specific gravity of 1018. Actually, it is a very poor question. I should not have given two alternatives with the same value. The answer is D. It is actually a very poor question. I especially read that it took me so much time because it is a poor question. It was a good question and I immediately answered. When I just added the question just to show you that if the question is not good, then also you will have problem in getting the correct answer. Actually, usually we say that if we are suspecting renal tubular defect, and if we take a warning sample of urine and check its specific gravity, if it is 1018 or more, then there is obviously no tubular concentrating capacity defect. That is what we generally say. It's a very simple test. You can ask the patient to collect the early morning sample of urine, you just check the specific gravity. If it is 1018 or more, then there is no renal concentrating defect. Why we have a specific gravity of 1010? Because the concentrating capacity has been completely lost. 1010 is the specific gravity of glomerular filtrate. There is no further concentration occurring in the renal tubule, so in chronic renal failure you get a fixed specific gravity of 1010, which we call as isostonuria. That is nocturnal polyuria. Normally you find that the night volume of urine excreted is half that of the day volume. That is what we normally find. During daytime, if you are excreting about 1000 ml, the night you excrete almost half or even less. An early indication of tubular defect is a reversal of the pattern. There is nocturnal polyuria. There may not be any other symptom. So that is an indication of an early tubular defect. Then massively low creatinine clearance. See, the problem with creatinine level is we all give the normal correct value of 0.7 to 1.4. Usually it will be somewhere around 1. But if the creatinine plasma level rises to 2, with all other factors remaining constant, the creatinine clearance value will be half. That is the formula for calculating clearance. UV by P. If the P has 1, you may get a value of 100 ml per minute. But if the P rises to 2, then the value will be decreased. So that is the significance of doing creatinine clearance in cases of renal disease. You will get a correct picture of the renal functional status by doing a creatinine clearance test rather than doing a plasma creatinine value. After you have made the diagnosis, to monitor the patient, you can simply do a plasma creatinine test. Sometimes in early kidney diseases, unless you do a creatinine clearance, you may not get a clear picture. So that is the importance of the creatinine clearance test.
Then, how will you diagnose a case of partially compensated metabolic acidosis? Low pH, low bicarbonate, low PCO2. Low pH, low bicarbonate, normal PCO2. Normal pH, low bicarbonate, low PCO2. Low pH, normal bicarbonate, low PCO2. Sufficiently complete, but there is no need. See, the question is acidosis.